So today for our webinar, how do you reframe healthcare around preventative care? I'm very pleased and honored to have three leading experts in this area who have not only led theoretically in terms of policy, in terms of really setting the narrative, but who have actually been hands-on in terms of making this happen. So first of all, I'm very pleased to have Ian Smith, who's the chair of the NHS Surrey Heartlands Integrated Care Board. With a career that's spanning healthcare, publishing and construction, strategy, consulting, and logistics, Ian has over 40 years experience leading highly complex multinational companies, including a number of chief executive roles. Previously, executive chair of Four Seasons Healthcare and chief executive of the General Healthcare Group, Ian has an in-depth knowledge of the healthcare system and patients' needs, particularly in terms of acute, psychiatric, and early care. Ian was also chair of King's College Hospital NHS Foundation Trust from 2017 to 2019, and is currently a non-executive director at the Ministry of Defense. Welcome, Ian. We also have Sarah Morgan, Chief People Officer, North Central London Integrated Care System. Sarah Morgan is an experienced healthcare professional with nearly 20 years experience, both operationally and at board level in the NHS, as health advisor for a large management consultancy firm and in policy development at the Department of Health and Social Care. She's currently working leading the workforce program for Southeast London Integrated Care System, which covers a population of over 1.9 million across 6 boroughs in London, with approximately 102,000 staff delivering health and healthcare. Thank you for joining us, Sarah. And then we also have with us today Dr. Linda Harris, who is the CEO of Spectrum Community Health, CIC. She's a former Wakefield general practitioner and clinical director, and she champions the needs of vulnerable people and has done this work for over 15 years. Linda is a trustee of Spectrum People, fellow and medical director of Substance Misuse and Associated Health for the RCGP. Welcome, Linda. So just to get us started, I'm going to ask each of our panelists to speak for approximately 7-8 minutes and just really give us a perspective on this very important topic of reframing healthcare around prevention. So we'll start with you, Ian, and we would welcome your remarks.
Thanks, Nora. So I'll be very brief, actually. I'll make a couple of points about integrated care systems and then talk about the preventative agenda. Integrated care systems came out of really 2 pieces of work or models. The first was Michael Marmot's seminal work on the wider determinants of health in 2010, which said that there is more to healthcare than an acute model. And the second was the US Accountable Care Organization model. And so those 2 things really came together to drive forward the creation of integrated care systems, which became statutory bodies in July of last year. Not wanting to be seen to be American, we changed Accountable Care Organization to Integrated Care Systems. And they are designed to balance the acute model, which obviously is still extremely important in our hospitals, with out-of-hospital care and prevention. In the UK, we set up a system in 1948 that was perfectly suited to the epidemiology of disease at the time. Small GP practices, district general hospitals, and really little or no social or mental health care because people mostly died at the age of 60 and within 6 months of their terminal illness. And rather shockingly, in hindsight, we locked up a lot of people in mental health asylums. That is completely different from the circumstances in 2023, where people live to the age of 85 with comorbidities, chronic disease, and an aging population. So social care and out-of-hospital care has become much more important. So the ICS is designed to integrate a highly fragmented system, which is really, in terms of the way it works and the way the patient moves through it, has barely changed since 1948. So the integration is especially between health and social care, which is currently a disorienting at best and harmful journey at worst for our citizens and patients. But also to integrate within the health service, because even within the NHS, we have a very fragmented, clunky environment with lots of different jurisdictions. And a key part of this is moving to prevention. And I think the big challenges there are working with local government, which is a separate system set up in 1948. I think over time, quickly, in my mind, we need to work to integrate health and social care and organize around patient pathways and make that journey, much safer and less disorienting than currently. In terms of the mechanisms for doing that, I think we have a pretty good model, actually, of extending these traditionally standalone GP practices into primary care networks comprising about 50,000 people each, but also then moving that so that it is much more integrated with council services, prevention, early intervention strategies with the council. That's not difficult. The councils have had a lot of money stripped out of them since 2010. And so they have done a lot of cuts in the things that would prevent ill health, particularly in schools, family centers, work with families. So it's not going to be easy, this move, but it's vital to do this. Otherwise, our acute system will be overwhelmed and we will bluntly let down our patients and citizens. I'm happy to come back to answer questions. Children's mental health is the one that's probably taking up most of my time. I think we are far too late in our intervention in preventing children's mental health, which is a tsunami, especially since the pandemic. We've had a doubling of eating disorders, self-harm and suicide since the pandemic. So I think that's the real cutting edge of where we need to make the integrated care systems work. So I'll leave it there, Nora, and pick up questions later.
Thank you, Ian. I'm going to move on to you now, Sarah.
Thank you. So I'm going to build on what Ian has described. So there's 4 core aims of an integrated care system around improving outcomes in population health, improving access and tackling inequalities in outcomes and also value for money. But the bit that I think is particularly interesting and is quite different to what we've previously had is also this commitment that we will support broader social and economic development. And I think that is where the wider social determinants of health, which we know impact on people's health much more than kind of just health itself, is really important. And that opportunity for us to really focus in a different way, as Ian started to describe, the opportunities there. I think some of the challenges are, how do we free up the headroom for us to invest in different ways, and how do we start to shift that dial? And I think one of the areas that I'm particularly interested in my role as the Chief People Officer is, of course, creating opportunities for our local population to have meaningful work and to create the good, the conditions for a good life. And part of that is supporting people into routes into health and care as careers, not just within the health service and local government, as Ian has spoken about, but also with our voluntary sector, charity sector partners, which are part of our integrated care systems now. So there is this much broader opportunity, and really helping our citizens and our residents to take their own health into their own hands. And we do really medicalize because of the way our model works that Ian's described, which hasn't changed since 1948. And I would argue, if Florence Nightingale walked through our wards, she probably wouldn't be out of place. We had, and I used to work in a hospital, St. Thomas's, and it had the outpatient bench that Florence Nightingale had put in there in the 19th century. So we definitely haven't moved our model forward, but it is a very paternalistic model, and it doesn't really empower the patient. As Ian said, it's very fragmented and dysfunctional in many ways, and it's set up for the organisation organisations and not the patients. So really pivoting and shifting that focus to our patients is going to be quite a challenge for us, really, but it's the right thing to do because of our rising demand from our aging population. We have the inequalities that the pandemic really shone a light on, that we know that particular communities really have much greater inequalities. And actually what we don't understand well enough, I think, is pharmacogenetics, and that what the impact of those therapeutics that we rely on have on different communities. And I think that is something, so there's some research around cocodamol and its efficacy in different communities, but it's prescribed uniformly. So I think there is quite a lot in our model that doesn't really serve the individual and the personalised care. And we have moved over time into more social prescribing. So for those that aren't familiar, that's where the prescription is more around social and community activity to help widen and people's sort of opportunities in life. And it's really for people in particular who are suffering from mental health problems, social isolation. It can have a much better effect than taking antidepressants, for example. So I think we've seen some really interesting research, but the normalization of kind of medicalization is something that we really need to steer away from. And being integrated care systems offer us an opportunity to work with our local authority colleagues in a way beyond social care, so economic regeneration and offering getting to understand our labour markets, understand our communities in a way that we really haven't done before. We've been quite passive, you know, build it and they will come kind of model, where we have more and more services and more people coming and accessing those services. And when Ian describes about children's mental health, I completely agree, because what we end up with is putting a lot of money into services at the other end, so either homelessness or drug and alcohol services or mental health services, where people's needs, if they'd been met or a different approach had been taken earlier in their life, we may not have some of those outcomes for our people. And we know that mental health prevalence has raised by 20% since the pandemic, as well as the raise in things like economic inactivity due to people having ill health, mental health problems, and also caring responsibilities. And I think there's a real opportunity for us to work together in the system to offer opportunity for people more flexibly, to allow them back into the workplace. If we put a lens on helping people into work rather than creating barriers for them, that can really help people's wider health, their ability to manage day to day and not actually access services as much as currently happens. So there's a lot of opportunity, but there is a lot of challenge with that. But it's quite an exciting time. I feel like we're in a once in a generation opportunity that I'm really excited to be part of. But it doesn't come without its challenges. So I'm going to leave it there, because I think Linda's going to give us some examples of how this works in real life.
Okay, thank you, Sarah. So good segue, and over to you, Linda.
Thank you very much, Sarah. And I was struck, and I'll follow on from you about your reference to setting up systems that are over-medicalised. And speaking as a GP, I always think if we get things absolutely right, success will be putting us out of a job, because prevention and health promotion will have taken the middle ground. So I share your enthusiasm. And just taking us into sort of some pragmatic examples. As a provider of healthcare, and Spectrum is an organisation, it's a social enterprise, so or otherwise termed a community interest company. So we deliver healthcare for a series of vulnerable populations, but predominantly we trade for a social purpose. And for my organisation, that means having the privilege of running a number of NHS contracts, predominantly within secure and detained settings, or prisons, we can call them. So for us, that means 21 prison healthcare sites across some of the most deprived parts of the north of England. And we've got a series of healthcare professionals working day in, day out, delivering integrated care within those services. And when I was asked, Nora, thank you very much for asking, I was thinking about how we deliver practically universal joined up health promotion. I just wanted to share some of the ways in which we're currently tackling that. So for each of our healthcare environments, we want to encourage a single universal health promotion strategy. And that does for us take a very much population health approach. So if you take a prison environment, it might care for 1,200 or 1,300 men. We would get to know that population intimately, their key demographics, the protected characteristics that they carry, the mental health prevalence of some key areas. And that is the fundamental population that we're working with. We encourage each of those establishments to have a health prevention champion, someone that is the go-to person that can really champion and be ambassadors for the message. But health prevention is very much a core part of the way we want to develop our leaders running our healthcare services. Making every contact count is also a philosophy we adopt. And by that, it means taking in some of the key determinants of health, the causes of the causes, and using every opportunity. So you might be seeing somebody for a particular consultation, but using that opportunity to pick up on other areas of their health and well-being. And that making every contact count philosophy is owned by everybody, not just the healthcare professionals, but also the colleagues and partners we work with. We also have site-specific suicide prevention strategies, as you can imagine, with a population of people with quite high levels of vulnerability, the risk of suicide, the risk of drug overdose is much higher. So as you might expect, we have a particular focus around suicide prevention and the prevention of overdose. As well as making sure that our population is healthy, we've seen health promotion as also including the workforce. So all of our sites are signed up to Better Health at Work Awards. These are charter marks so that our workforce's health and well-being is as much our business, healthy people delivering healthy contact. So living and breathing some of the health prevention strategies that we want to imbibe. We also have a number of public health dashboards, whether that's tracking our approach to infection prevention control, reducing or preventing communicable disease, reducing drug and alcohol treatment. And all of these are subject to quite rigorous targets that were set by our commissioners, because it's quite important for us that health prevention, health promotion is something that we're driving forward. And in our post-pandemic environment that they're now working in, we're very much signed up to focusing on some of the things that Sarah and Ian have already highlighted that we know are now key priorities for population health prevention. So, for example, for our population during lockdown, the prison population, just using them as an example, we were all locked down, and that included people being sometimes behind their cell doors for upwards of 20+ hours a day. And you can imagine, now we're tracking people's health, weight and physical exercise. We've got higher levels of obesity that we're dealing with. So we have a real focus at the moment on reducing obesity. And we also have a high focus on cardiometabolic disease prevention, particularly hypertension case finding, but also diabetic continuous improvement plans. So that's just a snapshot. And I just want to close by just picking up the point that Sarah raised around social prescribing, to talk a little bit about how we're making that real in a prison environment. And we have something in conjunction with the University of Central Lancashire. We've got something called the GOOP project, GOOP standing for Greener on the Outside in Prisons. And this is our opportunity for healthcare staff, prison officer staff, working with our academics to actually see horticulture and health in action. We've got some fantastic evaluation work going on where instead of giving people pills and potions, we're introducing to them the power of planting. And we're seeing some fantastic results now with individuals getting outside, being involved in horticulture, and actually we're seeing a reduction in depression, anxiety, and therefore the prescribing of those medications. So it's a whistle-stop tour of a few examples in practice, but I hope it whets your appetite in how we put some of the strategy into practice.
All right, thank you so much. And for the audience, we have a Q&A function down at the bottom of the screen. So your chat and your hand are disabled, but you can use that Q&A function now to start to put in some questions that I can ask to the panelists. So while I'm waiting on the audience to put their questions in, I recognize that we've got a number of people on this webinar who are from around the world. I don't think the issue of, reframing healthcare around prevention, as articulated by all of you, is anything we would disagree with. However, as we all know, there continues to be, not just in this country, in the UK, but worldwide, a lot of tension around therapeutics versus preventative care. So I would like to ask the panel, how do you see that tension? How do you manage that tension? How do you take a system that's really focused on hospitals and delivering that kind of care, treatment, because treatment often gives us instant results, or at least it's more quantifiable. Prevention is so difficult to quantify and really understand. And so how do you, as advocates of primary and preventative care, how do you get your voice heard, and how do you help to manage that tension that I know exists in the UK, and of course it exists in many countries worldwide? Who'd like to take that question?
Nora, I'm happy to kick off if you're okay, just because it's whilst you were talking about that tension between a medicalized model towards moving and shifting this towards a more psychosocial model is definitely something that we've had to take head on when working with the prison health environment, where, as you might expect, we are faced with individuals with a prevalence of high levels of substance misuse and mental health. And not surprisingly, quite a number of those individuals have relationships to medical treatments, including sometimes getting into a pickle with those treatments, so dependency on those treatments. And we now know through the evidence of trauma and the impact of trauma, which so often is related to people, developing behaviors and mental health problems later down the line. We know from the evidence base of trauma that trauma-informed practice really, the role of medicines in the long term, medication in the long term to tackle trauma is very minimal. And that's why I am so excited by and so happy to see our commissioners now investing in opportunities like the horticultural project that I talked about, like art therapy, like social prescribing. And therefore then it's up to us, the medical professionals, to work with our healthcare leaders to actually tackle head on some of this tension between prescribing and over-prescribing. So you will see in all of our prisons really proactive dependence-forming medication pathways, multidisciplinary and multi-agency working groups, backed by data-driven information that takes us on a journey with our patients. And I perhaps haven't often showed this enough. It's so important to have the voice of lived experience as part of that. Our patients are sometimes our best advocates. So working with our patients as well to help sell the message that actually there's a different way of tackling trauma. And that's just a couple of ways that we're managing that tension.
Great, thank you. Ian?
Yeah, well, I think the key to this is identifying the most vulnerable and high risk individuals. And as we'd all recognize, I think, the people who are probably most vulnerable have the least voice. And, population health management is going to be a key part of this journey. One of the things we're doing in Surrey, and actually I started it in Bromley when I was at King's, is to introduce a high-risk care management program. We're actually copying one by Partners Healthcare in Boston, Massachusetts, which identifies the most vulnerable in society. And actuarially, if you have about 300,000 people, which is the size of our places in our 1.2 million population in Surrey, typically about 3,000 or 4,000 people are high risk. And that's a lot of frail elderly with dementia, complex mental health, and of course, chronic conditions, COPD, and so on. And I think try to organize our system so that we identify those people and we put in MDTs, multidisciplinary teams, that isn't just a medicalized pathway. Of course, it should be if it needs to be, but looks at the whole person. So what is the housing situation? What is the mental health situation? How can we begin to shape our services around those individuals? And I think that then, and increasingly try to identify the people who don't have voice and arrive too late into our system. either at A&E or advanced conditions into GP therapy. So get ahead of the curve on this. And then secondly, really start building communities. I mean, one of the bigger social problems in the UK is that we have a highly centralized system that has sucked the energy out of our communities and local government over the last, for many, many decades, actually, but especially the last 15 years. In Surrey, we've identified the 27 towns and communities, each conveniently about 50,000 people, which links into the neighborhood team that I was talking about earlier, and start engaging with communities so that we, identify the people vulnerable there, but also, get self-care, get communities to rally around their vulnerable people, because we just don't have the money. The money is not there. So we are going to have to find voluntary organizations, engage much more with families and carers who are too often forgotten in this process, and with patients themselves, and begin to educate people about the harm that can happen and the bad results if they don't begin to address it.
Great, thank you. And Sarah, did you want to add anything here?
No, I'm happy if you want to take another question, or I think that's fine.
Okay, so my next question is really around, demographics. So in the UK, of course, we have an aging population, and again, many of them have come up through this system where they go to specialist care, tertiary care, and they see that as a right and the necessary way to be treated. So how do you get your populations to think differently? How do you get them to think about preventative care and to, be willing to look at a different model when they have their whole life been matriculated around hospitals and specialist care? So I'd really be interested to just know how you get your patients, customers, clients, whatever we want to call them. How do we bring society with us to understand this new approach to delivering universal healthcare?
Do you want me to have a start at that? So actually, I think our older generation are probably a bit better at using other services. They're often in voluntary sector, so they may be getting support by Silverline or Age Concern, or they're sort of in the charity space. The British Red Cross do quite a lot of helping people get home, things like that. So I do feel that the older generation, I think it's almost the middle, the people that grew up knowing only the NHS, rather than people that the NHS incepted. They had years where they knew how it was without that National Health Service. But I do feel like people do want to be part of community. The way that Ian and Linda described sort of the work that they're doing, people are attracted to that. They just want to have something that works for them. And actually, part of this is helping people not to have the social isolation. It can be very isolating, just going to be treated in a hospital and then coming home and being on your own. And actually, what we know is that a lot of GP and A&E attendances are people who are lonely, and they want to talk to somebody, and it is a real driver. So there is something about how do you fulfill that need and why people are accessing the services, because there isn't something else. And then how do you make different choices? So as Linda was describing, commissioners making different choices. So part of the role for us in integrated care boards is how do we make the brave decision to fund some of these other interventions that we know will have a longer term? And that is the conversation that we're having a lot. How do we make our population health improvement strategy real by making the investments in the different kinds of services with our voluntary sector colleagues, with our charities, things that like the Green Project that Linda's described? How do we make those choices? And it is challenging, but we have to do that to start to shift the dial, because there has been a huge uptake in social prescribing. People are hungry for this. They just don't know how to access it. And our job is to make it easy for them and to help them see the benefit of it. And maybe not have as many pills and potions as Linda described them, because they're not always very healthy for people in reality.
I'm
Sorry,
happy to follow on from. Oh, sorry, Ian.
go ahead, Linda.
Oh, thank you. Well, I was going to reference both you and Sarah because, Ian, I was struck by your really articulate, and obviously your experience of building communities. The only thing I would add, and I've already alluded to it, is the power of lived experience. And I think when you're talking about people who are in real vulnerable circumstances, you mentioned health inequalities, who are really, subject to health inequalities. Quite often, they are the individuals whose voice is seldom heard, but their lived experience is what we need to bring to the fore. And we are on a journey as an organisation to doing that. I think we have probably a good strategy now. I think there's something about ward to board. We need all organisations to own and to really be signed up to how lived experience is visible within the way we deliver care, and that sometimes means having good inclusive workforce strategies as well. So, bringing people with lived experience, giving them the opportunities to actually join the health and care workforce themselves, so they become integral to the actual provision. And there are sometimes constraints to that, but we're looking really head on. So, for example, people who might have had an experience of the criminal justice system, how can we get those individuals to have opportunities to join the workforce? That's really, really important. So we take peer mentorship seriously as well. It's like volunteering. It has a value. People who give of their time to be peers and advocates should be valued, which means we need to train them, educate them, support them, and supervise them. And for us in our prison estate, we have designed a peer mentor program. There are lots of them about, but taking people who put their hand up and say, I've got lived experience, but I want to become, a better advocate. How can we give them education and training? So I do think it requires real active, proactive things that we have to invest in and value. Yeah,
absolutely. And I think, again, it is focus on the individuals, because I think, if we do sort of broad public health stuff, I worry that it doesn't get through. Stop smoking campaigns. It's much more powerful to talk to those people directly and understand their circumstances and design a bespoke, customized program. One program we did at King's, the respiratory team at King's, when somebody came in with a respiratory problem to King's, we actually put a team in to go and talk to that person about stopping smoking. And, those people are much more alert and open to listening to that when they're sitting in a hospital bed ill, So I think we've got to find ways of identifying those people and personalizing that intervention. I think the other thing that the NHS has not been very good at in the past, and, I think both Linda and Sarah have mentioned it, is getting the carers, the families in the room, and getting the voluntary sector in the room, but organizing them, because they can be quite a Tower of Babel if you don't ask them to organize and have a single voice. So I think in Surrey we have been pretty good. Actually, we've got our head of carers, Sue Tresman, on the board. We've got a single voluntary representative of the voluntary sector on the board, and the third group of people, which having worked in the social care sector, care homes, still makes me angry. The dom care and care home providers just are not at the table at any of these discussions. They represent 1.5 million workforce. The workforce in social care is the same as the workforce in the NHS, but they are the forgotten people. We have luckily I think in Surrey, we have a single representative of the dom care and care home providers on the board of the Integrated Care Partnership. And I think those are some of the ways of teasing apart this over concentration on the NHS and over medicalized pathways. But I'm sure Sarah will agree, if somebody goes into hospital, you really want high quality medical attention. So, we're not talking about undoing the hospitals. What we're talking about is taking the activity that should not be there, preventing people going there in the first place, but taking people out faster who should not be there. I think as many as the figure is usually 15% of people stuck in hospitals should be there. I think it's about 40% actually, because I think a lot of the assessments aren't done. But we do need those hospitals to be highly medicalized and competent and leading edge in biomedical science as well.
Okay. Well, those are really great answers. I've got a question from the audience. Given the pressure on GP practices currently, what are your thoughts on how we help PCNs to engage with those with lived experience and move away from this medicalized model? So really good question. Who'd like to take it?
I'm happy to start, and it's a great question. It's a very, very good question. So I'm a GP by background, but actually for quite a sizable amount of my professional career, I've been working more in a systems way. But I have recently, we've been recently working with a GP practice with a high index of multiple deprivation and grappling with things like the Tudor Heart Law. So, you know, quite often it's individuals with the most health inequality that don't get what they need. But I think this is there is an awful lot of pressure in practices, and we need to think of a way, and PCNs could be a way through collective working to enable us to lift to people to be able to lift their heads up and be able to do what we've been talking about today, Nora, and thank you for talking about how to do health promotion well. And the population health approach, the registered practice approach, which I truly believe in, is such a fundamental building block to that. And last week in this little GP practice, we had a little showcase event and we invited patients to come, and I was delighted. The car park was full and people came, and they came together and they didn't discuss pills and potions. They were talking about their general practice in the heart of their community. And we started to build up a dialogue, which after the pandemic and with all the pressures in general practice probably just diminished a little. So it was really, really nice to start to give people the opportunity. We closed the practice down. We used the practice protected learning time session to open our doors, put up stalls and get people talking again. And as a result of that, we had a number of our patients signing up to want to get more involved in the patient participation group, to want to get more involved in the local voluntary community sector cancer talking cancer service. So it's grassroots ways of doing it, but I really felt heartened after I saw that event done at practice level, but using the primary care networks to organize ourselves to do more of that.
Yeah, that's really good. I'm gonna now move to a different question. It's from an aspiring student in accounting and finance, and as you can imagine, young people today are just as aware as you are about the mental health challenges that their generation has. And I recently saw a World Health Organization statistic that was really alarming about the rise, particularly around those around 20 to 25 worldwide facing such challenges. So in terms of thinking about prevention of mental health disease, where does the finance, the money come into there? And what are the things that are the enablers, and how can we get that kind of shift change around such increasing alarming diseases like mental health, trauma, and suicide? Ian, do you want to take that?
Yes, I do. Well, firstly, the money is not easy. I mean, the idea of taking money out of the acute trusts and putting it into community, if it was the private sector, you would say, the payback on that is massive. It costs what, £1,500 for a week's very advanced domiciliary care, or £1,500 in a care home, compared to about £4,000 in a hospital ward. And if we've got 15 to or 20 to 40% of people stuck in hospital, that is inefficient. The problem is each budget is separately held currently, although we will change that, I think, over time with the ICSs. And even so, we are trying to build that transformation at a time when all of our budgets are being constrained, especially Sarah's and mine, actually. So, as I say, in the private sector, you'd say, let's put 50 million into this program. we get a return, in 2 or 3 years' time. It'll have a very high IRR, but that doesn't happen in the NHS. So we have to do this. We have to do this as we work. And I think the key to it is what we've talked about. I think we do need to mobilize communities. I think we need to take the pressure off GPs so that they can engage with their patients, because they do care. So we need to find urgent care pathways out of hospital and out of GP practices, that take that traffic away. We need to get ahead of the curve with population health management. So we're getting much earlier intervention, specifically on mental health. I think teaching resilience in schools, the dangers of social media. I think many of those programs, Sure Start, many of these programs have been cut over the last few years. We've got to find a way of investing back into those, because the acute, with all of this ending up at the acute end of the spectrum, it's bankrupting the system, and it's hugely damaging for children. So I think we need to get families involved. We need self-help, teach children how dangerous social media is, teach resilience, and get the schools to mobilize to engage with the students early on, because, as I say, once they get onto an ADHD or an autism pathway or an eating disorder, we've already failed them.
Sarah?
Yeah, and I think that this is where I think being a research and evidence-based kind of approach to ICSs is really important. And then the challenges, so you find out, so it's likely that, you find out that you put money higher up the, upstream, and then you will save money in the acute end, as Ian's described. But then how do you create that headroom within a constrained budget to make that commissioning choice real, so that patients can actually get that service and that care? And I think that's where some of the innovation that Ian's just described is, it doesn't necessarily always need to be us doing it. I think the NHS has a real tendency to say, oh, that needs to happen, right? Well, we need to develop a new service, or we need to do it. Actually, how do we then use the power of the partners across? How do we maybe upskill the unpaid workforce, the informal carers? So for us, that's over 100,000 people in our sector who are caring for a loved one at home. How do we help them to be more educated so that they can support? So it doesn't necessarily always need to be within the institutions, if you like, but we do need to support it and make it so that it's able to happen. And I think that is our conundrum and our challenge, and we're not quite there yet working that out, but that is the intention. But we do need to have that sort of research to help us, I think, and that links to digital as well, which I think is another question in the chat, Nora, you might want to come on to. But having that digital technology, but then helping the workforce to change their working habits and their clinical practice so that the digital can actually make a difference. Because the challenge often is we put digital in, but we just carry on working as we've always worked, and we don't realize the benefit of digital, and then you get a lot of burden and overwhelm. So I do think that we do need to help people also shift how they work as well as where they work, is part of this.
So that's really good. And I think my next question then is around the use of telemedicine. And again, it's an example of digital health and technology. One of the biggest criticisms, of course, of technology in general and in the healthcare space is it doesn't drive down costs. So how do you see digital health fitting into the work that you're doing? And particularly, it's interesting, during the pandemic, of course, we saw a big rise in telemedicine. We, in places like the United States, it really took a leap forward where, you could be in hospital and see your physician from your bed. And yet now, post-pandemic, as the pandemic starts to wind down, we're seeing the use of telemedicine dropping significantly. And interesting enough, we're seeing it drop in places like care homes, where we would normally have expected telemedicine to, stay high. So what do you make of all that? And how do you see technology and particularly telemedicine figuring into the future? Was it just a hype and a buzzword for a moment, or it, does it have legs, and how do you see it coming in?
I mean, I will just share one reflection, and then Ian, you might want to come in on this. So quite a long time ago, I led a pilot that we did on telehealth and telecare, and kind of the thing that I just alluded to was that the clinicians didn't change their practice. So yeah, they had it as an additive rather than part of a care package. So we didn't see the advantage, and then you didn't see the change in how patients experience their care either. It's just an added thing that they had to do because they were still seeing the clinician as well. So I think there is something about what we didn't do during the pandemic. Everybody saw it as kind of a short term, we can sustain it and we can keep going and we can keep going, oh, right, okay, well, we can go back now. And I think we've retreated back, and we're so busy trying to keep on top of the waiting lists and we've retreated back to what we know, which is just continually on this sort of hamster wheel, really. And I think that's why the technology is not embedded, because we didn't change the working practice in a sustained way. It was seen as kind of this moment in time, and we did predict that. I don't think it's a surprise, because we all predicted and said, wouldn't it be terrible if we just went back to how we all were before? And actually there's a little bit of we did that. So there is something about how do we recapture that? How do we make conscious effort to bring technology to augment the pathway properly and not just add it on, bolt it on and just work around it, which is what we have a tendency to do.
Ian, did you want to follow up, and then Linda?
Yeah, well, a couple of things. I think one, the lessons in applying technology have been learned. I've learned it painfully over my management career, and it is get the processes in place before you throw technology at it. You really have to get the people in place, get that process in place, and then use technology to support that. Now, many companies make that mistake, but the NHS makes it pretty often. And throwing in technology is just going to be a waste. And it comes back to the funding point. A lot of it's funded on short-term project funding, so you have no long-term view, and then the funding runs out, so you stop the program, and that's no way to do it. I think the other just small point, again, having come from the social care sector, I think the dom care providers and care homes, the bigger ones have some great technology. I mean, they are pretty sophisticated operators, again, not understood within the NHS. I think they felt very done to at the start of the pandemic with clearing the hospitals. I think then there was a period where they were invited in because they were a key part of this. I feel they now feel they've become an afterthought, and I think we need to engage very strongly with the dom care and care home providers, leverage their technology, and build that into the processes and the people transformation that we need to undergo.
Great. Thanks. And Linda?
Yeah, no, actually, I was really struck by your comment about research showing the dip in this post-pandemic, because that is exactly what I have experienced. And we were often in prison environments, we're often coupled with the care home sector. We are different, but they're often compared. So I don't know the reason why, but it's been something that I can definitely concur with. What I was starting to see pre-pandemic was a bit more of a process-driven introduction of telemedicine, particularly between the acute sector and the community sector. I was seeing it, and then it's just been very disrupted and overtaken by rather, I would say, old-fashioned use of telephony and more sort of transactional methodology, which I don't think gives as good a patient experience. So I'd love to know a little bit more as to why that is, and I'd be really interested in being part of that such research. And I concur with everything that's been said, but I just want to mention a little bit about artificial intelligence, because I don't know much about it, but I think when we talk about digital and telemedicine, and we talk about the power of health promotion and health prevention, good quality screening can, I think, be done very effectively from what I've read and potentially had it seen by perhaps introducing a very consistent chatbot-y type approaches so we do our screening, because I have a hunch that screening is done inconsistently, and therefore we don't get the maximum evidence-based benefit from it. So I just wanted to sort of shout, I think there's huge potential from visualization and consultation, but also artificial intelligence digitally as well.
Great. Well, look, we're almost out of time. So I have one last question, and I'd like all three of you to answer that question. What lessons do you think the UK could learn from other countries in this preventative space and vice versa? So what could we learn and what could other countries learn from us? What do we do well and what do they do well?
I'll kick off but be very brief. I have to hold my hand up. I don't think I know enough internationally about what is out there. So perhaps first part of my answer to this question is we have to become better educated, and I can hold my hand up that I perhaps don't read enough or know enough, or I'm naturally connected globally. I had the benefit of going out to see and visualize a European model of neighborhood nurse-led community practice a few years ago. I was blown away by it, and I made some attempts to share some of my experience a few years back to see whether or not we could take the lessons from what was a very successful nurse-led preventative model in community working in a European country. So number one, I'd love to learn more, and number two, when I've tried to do it, perhaps it hasn't landed as well as I'd have hoped.
Okay.
So I think there's a lot we can learn from countries that do community better. And I was listening to a really interesting radio program about Taiwan and the work that they've done on place-based community and having sort of place leaders, which is sort of what we're aspiring to, I think, in ICSs, and how that looks at all the determinants. So not just health, but well-being, the community, the cleanliness, how people experience their environment, etc., which I think is really interesting. I think what we do well, and it has a time and place, is the universal healthcare. I think how we could coordinate during the pandemic, because we had the single NHS, just focusing on that, I think did show the benefit that it brings, but obviously it has its downsides as well. So there's always learning, I think, to have internationally, that we, and when I was in the Department of Health, we did do quite a lot of that, and there's so much value in it. It's just having the time to put your head above it and create the time and energy to pay attention to other things, isn't it? Which I think but it's great to do.
Yeah, I mean, I think you also asked the question, what are we good at? Actually, I think the NHS is very good at things. It's very good at crisis management. I mean, I think the vaccination program, pandemic, winter pressures, when it really mobilizes, the NHS is very good. It's very good at trauma. I think, the acute end, certainly at King's, our major trauma unit there is world class, without a question. The problem is that I think that crisis management mentality gets in the way of actually putting in the processes and getting to the root causes so that we fix the winter problem or discharge and don't stumble into it every year, because it takes us by surprise. We do know the seasons occur. I think in terms of, so there are good things about the NHS, let's lose that, but we do need to begin to take a longer term or process driven view. In terms of countries, I think Holland is extremely good. I think parts of the United States, clearly they've got a problem with the 40 million or so people uninsured. So if you're very poor and disadvantaged in America, you're probably worse off than almost anywhere in the world, actually. But there are some places, Partners Healthcare, Kaiser Permanente, there's an awful lot to learn, and often in England, we sort of write the Americans off, which is quite false. They are very good at some parts of this, and the Partners Healthcare in Boston, Massachusetts is a great model. And finally, the Scandinavians, I think they have figured this out extremely well. And also I'd mention the Israelis. I think organizations like Clalit in Israel are excellent, and they have solved this out of hospital. Much lower percentage of their health spend goes into hospitals, much more into community and out of hospital compared to us. So we've got a lot to learn.
Well, look, I really appreciate your time. It's been fantastic to have you today at the Global Business School for Health to talk about preventative care. And I wish all of you a great success on behalf of the British public. Again, thank you for your time, and thank you for our audience and for joining us and listening, and have a great day. Take care. Bye.